Hi everybody, this is Alec with Home and Rehab, and today I wanted to talk about something that's extremely important and kind of newer in the research community, and that is the importance of correlating what our findings are on visual imaging, like things like our X-rays, MRIs, CAT scans, with symptom presentation in clinic. It's something that we found needs to be evolved in the field of medicine. It's how we interpret our findings on an MRI, because the things we've been finding have not necessarily been matching up with symptom presentation, and we need to do a better job in our field of communicating what we're seeing and making sure that it matches what you're doing. On the majority of MRIs that I receive, we have a little caveat at the bottom, and that is that these findings may be clinically relevant given the correct presentation of symptoms. Now this is extremely important because the majority of the time that a radiologist gets a referral, what they're told is a generic area of pain, for example, shoulder pain. Now, how shoulder pain presents in different types of conditions varies, but an important thing to remember is that when we take a look at somebody, the findings on the image are not necessarily reflective of exactly what your presentation is. A great example of that is a study that showed very recently the differences, or the similarities rather, between two shoulders that are one in pain and one not. So, what we tended to assume for a very long time was if I took somebody with shoulder pain and found a rotator cuff tear, for example, that automatically indicated that that tear must be what's causing their pain. What we did recently, however, was we decided to compare our symptomatic shoulder with the asymptomatic shoulder, the one that hurt with the one that didn't. And what we tended to find was the vast majority of these patients, one who had a painful shoulder and a non-painful shoulder, when we did the MRI, they both had tears. What that tells us is that the tear might not have been what's causing the pain, that we need to reevaluate our understanding of how pain is produced by the body. That's something we're actively working on in medicine right now, and trying to get a better understanding of this is hugely important. But what it means is we always need to take these comparative studies. Alright, if this shoulder hurts and this one doesn't, but they both look the same on the image, maybe what I'm finding on the image doesn't match, and that's okay. It just means we need to dig deeper in our diagnostic procedures. So what do? Well, we need to do a thorough clinical exam. What that means is when you come into a physical therapy appointment with someone like myself or my colleagues, you should be getting a relatively long physical exam that includes a very detailed history of your problem. When did it start? How did it evolve? When you are active, what does it feel like? When you're not moving, what does it feel like? What things make it worse and what things make it better? Then from that, I need to tailor down and go, all right, I'm also going to do a series of physical tests. When I stress certain tissues, are they painful? If I stretch them, if I work them, if I touch them, what do they feel like? If I put strain through the meniscus of the knee and it doesn't hurt, does that indicate that even if there is a present meniscus tear, it's a problem? Often no. We tend to find a lot of people who have no pain or issues with their function in the knee have meniscus tears in both knees, and we may see evolution of pain that is completely unrelated. It's perfectly okay, but it means that there's something that we need to keep exploring. So, when we're looking at our imaging findings, it doesn't mean what's on the image doesn't mean something, but it means we have to correlate that to what we're seeing in our clinical presentation and make sure they match up. Because if they don't, it means we need to explore further. So, what that takes a look at is, alright, if I see somebody who has a history of back pain that started a couple weeks ago, and I do an x-ray on them and I see that their bones are very close together, that could mean that the patient has arthritis in their back. But the presentation of arthritis is very, very clear. Their pain should be worst in the morning when they first wake up and haven't been moving for a long period of time. With gentle progressive movement, they should feel better throughout the day, and their pain should gradually alleviate the more gentle movement they do. The majority of the time when I have patients come in with a diagnosis of arthritis, they don't necessarily match that. Because what our old procedure was we take a look at somebody, we see they have pain, we see their bones are close, we decide it must be arthritis. But just because our bones are close to touching does not necessarily mean that they are causing problems to one another. It just means that there may be something in that area. But if our clinical presentation, when I come in, I don't describe, oh yeah, my back pain is worst right when I wake up, but the more I move, the better I feel. Alright, if that's not what I'm saying is probably not consistent with arthritis. So I need to look deeper. Alright, what else might be going on in that region? If it's not the bones, there's plenty of other stuff in my back that could be causing potential issues. One of them could be issues with the musculature, ligaments, tendons, or nerves. And none of them show up on x-ray. So just because my x-ray shows one thing, if my presentation doesn't match it, I need to check the next. And that's what we should be doing in medicine on the whole. If I come in with a disease presentation to a clinic and they do any sort of testing on me and they find that when they do the microscope test, it looks like there may be a specific kind of bacteria present in my system, they do further tests to make sure that that bacteria is exactly what they think it is. So why don't we do this with pain? Because we're still learning about it. We're doing more and more, and your doctors are doing more and more along with us to make sure that everything we find correlates and makes sense. But it's something we're still learning a lot about. More and more studies are coming out every year about the complexity of pain, and we are learning more and more about what we can do for you. But patience, unfortunately, is going to be our virtue in the field of medicine when it comes to these things, because we are still evolving how we approach it. And that's perfectly okay, as long as we're willing to adapt. So, you'll notice that people like myself are reading research almost every single month to make sure that we're caught up on what's going on in the system. Why? Because we want to learn. And we're doing this for your benefit to make sure that we can help you even better. So what I'm doing today might be different than what I'm doing tomorrow, especially because as of February 1st, I'm going to get a brand new set of journals to read up on and see what can I do to better help you. All these changes are important because we're constantly learning more about the human body and how complex and wonderful it is. But it means that I'm always learning, and I'm always finding something new to try and help you out. If you guys have more questions about what might be present or what might not be on certain types of imaging, let us know. These are things that we really enjoy talking about, and we're always happy to help. Have a great one.